alpha-1 antitrypsin deficiency and cystic fibrosis, though infrequently diagnosed in India, continues to be examiner's favorite when it comes to super specialty entrance exams. Okay. In the current module, we will look into alpha-1 antitrypsin deficiency. To start with, let's take few questions. The first question reads, a 35-year-old man with 10 pack years of smoking history who was diagnosed with COPD and emphysema. The diagnosis was based on PFT and HRCT report, and on evaluation they noticed that his serum alpha-1 antitrypsin levels were low. The question asks the increase in the activity of which of the following serine proteases explains this patient's disease process. Options include elastase, trypsin, chymotrypsin and bombesin. I agree that alpha-1 antitrypsin has activity against trypsin, but that does not explain the disease process. The question is pointing at alpha-1 antitrypsin deficiency. To begin with the initial diagnosis of COPD, I do agree with the diagnosis of COPD emphysema because it is based on PFT. Remember, the diagnosis of asthma and COPD are always based on PFT, not purely on clinical grounds. So that condition it satisfies. So there is COPD, which I agree, and the blood evaluation suggests that the alpha-1 antitrypsin activity is low. So the patient is suffering from alpha-1 antitrypsin deficiency with its manifestations. In the lungs, it is not the trypsin which is causing the damage, it is the elastase. To be precise, it is the neutrophil elastase. The alpha-1 antitrypsin majorly acts against neutrophil derived elastase. In the normal person, since the neutrophils form a very minuscule number of cells in the pulmonary architecture, there is very minimal neutrophil elastase activity. But for those who smoke, because of the neutrophilic inflammation, they have more neutrophils in the lung, and that leads to increased neutrophilic elastase production, and that explains why these patients develop emphysema. Let's take the next question. The next question says, a newborn was subjected to screening for alpha-1 antitrypsin deficiency by immunoreactive trypsinogen. Though we don't do screening in India, the Western world, Europe and US, they screen the newborns with immunoreactive trypsinogen assay. They do a heel prick blood sample and subject it to immunoreactive trypsinogen assay. So based on the screening, he is suspected to have alpha-1 antitrypsin deficiency. During the follow-up, 20 years later, he was found to have severe alpha-1 antitrypsin deficiency. So in the blood activity of alpha-1 antitrypsin is very low. His PFT showed normal values and there was no evidence of emphysema or bronchiectasis on HRCT thorax. The question asks, which of the following statement regarding augmentation therapy for this patient is true? The diagnosis is correct. He has alpha-1 antitrypsin deficiency. It is not manifesting with PFT or HRCT abnormalities. Let's look at the statements made. The first one, consider augmentation therapy with weekly IV infusions. Remember, the question says there is severe alpha-1 antitrypsin deficiency. The second option says, consider anti-inflammatory macrolides. Option C is phosphodiesterase inhibitors. And option 4 is augmentation therapy is not recommended. Which one is the right answer? Let me first talk about phosphodiesterase inhibitors. Phosphodiesterase inhibitors, mainly roflumilast that we use in pulmonology, is used for preventing exacerbations in patients with COPD, mainly the chronic bronchitis variant. It has of no role in patients with alpha-1 antitrypsin deficiency, where we see emphysema predominant COPD. Then again, anti-inflammatory macrolides. There is no trial demonstrating efficacy of anti-inflammatory macrolides in patients with alpha-1 antitrypsin deficiency. The macrolides like azithromycin have shown some efficacy in preventing exacerbations in patients with COPD who was a ex-smoker. But since there are no trials supporting its role, that is not an option. So we are left with two options, whether you give the augmentation therapy or whether you don't give the augmentation therapy. The guidelines recommend that we should be giving augmentation therapy for those who have severe deficiency due to PIZZ or PIZ variant and have evidence of pulmonary involvement. Since this patient, despite having the severe deficiency, has no evidence of pulmonary involvement and hence is not the candidate for treatment with augmentation therapy. The next question reads, a 52-year-old patient presented with COPD and liver dysfunction. So he has two organ involvement, COPD and liver dysfunction. He is a known alcoholic. To confuse you or to make a point that he carries a risk factor for liver disease, and he is a known smoker. So he also carries a risk factor for developing COPD. When his liver biopsy was done, it shows PAS positive globules within periportal hepatocytes. Which of the following is the most likely diagnosis is what the question is asking. So as I told, there are two organ involvement, lung and liver. Though the question gives the possible risk factors for individual organ involvement, whenever we are facing with a question or even in real world situation we have a patient, we should always make first attempt to explain the entire spectrum of manifestations with single entity. Only when that is not possible, we will consider multiple diagnosis. So applying that principle here, there are only two conditions that I know which present with involvement of both lung and liver. They are alpha-1 antitrypsin deficiency and cystic fibrosis. So as of now, I will assume that I am ruling out alcoholic liver disease. These two becomes my prime suspects. Why has he given glycogen storage as an option? PAS positive globules are also seen in patients with glycogen storage diseases. Okay. PAS basically stains glycogen, but it can also be positive in patients with alpha-1 antitrypsin deficiency. If you have to rule out between two, generally the pathologist subject a specimen for digestion of collagen and then stain for the PAS. Post digestion of collagen, if it is PAS positive, then it is possibly alpha-1 antitrypsin deficiency. But in most cases, we have clinical history which will help us in ruling in or ruling out. Here I am considering the diagnosis as alpha-1 antitrypsin deficiency. I will tell you why. Between the two, between AATD and cystic fibrosis, my leaning towards alpha-1 antitrypsin deficiency stems from the patient's age. Most patients with cystic fibrosis usually develop cirrhosis before third decade. I don't mean again all those patients who have cystic fibrosis develop cirrhosis, but those who have severe CFTR defect, those who have the propensity to develop cirrhosis usually manifest before third decade, and majority of them come to the light in the childhood itself. On the contrary, in patients with the alpha-1 antitrypsin deficiency, the presentation of liver disease varies significantly. It may present in childhood or adulthood as late as 5th decade. Another point that makes me think of possibility of alpha-1 antitrypsin deficiency over cystic fibrosis is the patient's age again. The normal life expectancy of cystic fibrosis patients currently averages at around 40 years. Though with intervention and newer drugs, in certain countries it has reached close to 50 years. But mean survival is up to 4th decade. So since this patient is past 5th decade, I would consider alpha-1 antitrypsin deficiency as the primary diagnosis here. Okay, now let's look into the alpha-1 antitrypsin deficiency as a disease. The alpha-1 antitrypsin deficiency is seen in 1 in 2500 to 1 in 4000 population in US. We don't have any Indian data on this. This accounts for 1% of all COPD patients. So it's not accounting for the major chunk of all COPD patients. Not all patients who have alpha-1 antitrypsin deficiency develop COPD. Alpha-1 antitrypsin deficiency is the most common monogenic cause for COPD. Now let's look into the alpha-1 antitrypsin per se. Alpha-1 antitrypsin is a serine protease inhibitor. It is encoded by a gene called serpin A1, which is located on the chromosome 14. To be precise, the long arm of chromosome 14, long arm denoted by Q. Alpha-1 antitrypsin is a 52 diopter, 52 kilodalton protein which inhibits elastases and other proteases. It is primarily produced by liver. In the lungs, it is produced mainly by alveolar macrophages. Alveolar macrophages, and to some extent by bronchial epithelial cells. The genetics of alpha-1 antitrypsin deficiency is interesting. As I told you, it is coded by serpin A1 gene, which has 4 allelic variants. This is one of those diseases which is inherited as autosomal codominant trait. Autosomal codominant condition. What do I mean by codominant trait? Codominant is where both the alleles are expressed. Both the alleles result in production of their proteins. In the patients or in the conditions where we call them as autosomal recessive or autosomal dominant, the dominant trait is one which is expressed and the recessive allele is not expressed. But here both the alleles are expressed. That's why we call it as codominant condition. As I told you, we have 4 alleles, allelic variants. They are called, the common one is M allele. Then second one is S. We have Z and a null allele. The M is the commonest allele and it is associated with the highest output or highest production of alpha 1 antitrypsin. The S is associated with slightly reduced production of alpha 1 antitrypsin. Z is severely reduced and null allele, as name says, nil, no production of alpha 1 antitrypsin by the allele. Based on various permutation and combinations, we may have MM variant, or which is usually normal and associated with abundant production of alpha 1 antitrypsin, and those who carry two Z alleles or one Z and one nil allele are associated with severe alpha 1 antitrypsin deficiency. The other combinations such as MS or MZ or SZ are associated with intermediate or milder variants of alpha 1 antitrypsin deficiency. How to remember these four alleles? Point 1, M is very common, normal. So common has M, that's M. S is associated with slightly reduced activity. Z is close to zero production and hence it's Z. Null, as name says, nil. Coming to the clinical features of alpha 1 antitrypsin deficiency, it affects two organs predominantly, lungs being the common, followed by liver. In the liver, the involvement manifests in the form of cirrhosis. In the lungs, they are at increased risk of developing COPD, to be precise, emphysema. There is no significantly increased risk of developing chronic bronchitis in these patients. But as I told you earlier, not all patients who have alpha 1 antitrypsin deficiency develop COPD or emphysema. Okay. To understand why this disparity is there, we need to know what is happening in normal condition. In normal condition, there is abundance of alpha 1 antitrypsin in the lungs, but very minimal neutrophil elastase. That is because in the normal condition there is no neutrophilic inflammation of the lung, and because of that there is not many neutrophils, and hence there is balance tilted towards abundance of alpha 1 antitrypsin. But in patients who smoke, the balance tilts towards increased neutrophilic elastase because of infiltration of the lung tissues by neutrophils, and hence there is inadequacy of alpha 1 antitrypsin. Those who smoke provide the second hit. The first hit is alpha 1 antitrypsin deficiency itself, and smoking induced neutrophilic inflammation of the lung is the second hit, and that explains why not all develop COPD, but those who smoke carry significantly increased risk of developing COPD. After we have known the clinical features, we should know how do we manage these patients. Treatment is only indicated for those patients who have one of these mutations, either PiZZ or PiZ mutation, along with the involvement of lung. Those who have no evidence of pulmonary involvement are not the candidates to receive treatment. Treatment is given in the form of augmentation therapy. So alpha 1 antitrypsin sourced from normal people's serum is injected in the form of IV injections on a weekly basis. Studies have not proven whether use of alpha 1 antitrypsin in these patients significantly improves the life expectancy, but it does improve lung function and parameters. Okay.